From gender-specific side effects to transgender psychopharmacology, we wrap it all up in this final episode of Psychopharmacology in Women. Welcome to the Carlat Psychiatry podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue.
In this episode, you'll learn how side effects and drug metabolism differ by sex, how to select psychiatric medications to protect the bones and prevent urinary incontinence as women age, and our top treatment for SSRI-induced sexual dysfunction. We'll cover why recreational drugs are more dangerous in women and how little we know about psychopharmacology in transgender patients. At the end, you're going to learn about a new use for atomoxetine, Strattera. As this preview of the CME quiz shows, you can earn CME for each episode through the link in the show notes. True or false? In sleep apnea, atomoxetine improves the hypoxia index, but only in combination with a muscle relaxant.
Pearl number 9, urinary incontinence.
As people age, to paraphrase Yeats, the bladder does not hold. After age 60, about 40% of women and 20% of men have urinary incontinence. In women, the most common cause is a weakened pelvic floor. That causes stress incontinence, where coughing, sneezing, or laughing triggers leakage. Childbirth, pregnancy, and menopause all contribute. In men, urinary retention is the more common type, and it causes urge incontinence, a sudden intense need to urinate followed by involuntary leakage, and it's often tied to problems like enlarged prostate or to prior prostate surgery. Urinary retention is 13 times more common in men than women. These may not be psychiatric conditions, but they do affect psychiatric prescribing.
For women, the SNRI duloxetine may provide relief. By tightening the bladder sphincter, this noradrenergic reduces the risk of stress incontinence by 50%. In some countries, it's approved for this. That same mechanism, though, puts older men with enlarged prostates at risk for retention. So consider duloxetine in older women, but use it with caution in older men. Another one to watch for in older men with prostate problems is anticholinergics. These cause urinary retention, which leads to bladder infections and urge incontinence.
Number 10. Side effects in women.
Our job is to assess risks and benefits with meds, and some risks are worse for women. Women are more prone to weight gain, hyperglycemia, and cardiac arrhythmias with psychiatric medications. Men face a higher risk of priapism with trazodone, a rare but serious adverse effect involving a painful sustained erection, though the female equivalent can occur as well. There are rare reports of clitoral priapism on trazodone.
Both sexes develop sexual side effects on SSRIs, and the best studied remedy for men also works in women with SSRI-induced sexual dysfunction, the phosphodiesterase 5 inhibitors. Most of the trials use sildenafil, Viagra, but I usually prescribe tildenafil, Cialis, for its longer half-life and 36-hour duration. That allows for greater spontaneity.
Okay, not to kill the vibe, but there's actually a lot of research on whether spontaneity is important for sexual health. In a sense it is, but only because thinking makes it so. When researchers help busy adults change their beliefs about planned sex, the dampening effect of scheduled fun disappears. They enjoy it more, have it more often, and develop stronger relationships. So let's not reinforce rigid ideas about spontaneity, especially if we're talking to working parents who need to schedule it in.
Okay, good point, but I'm still going to prefer tadalafil, Cialis, because I don't want patients to get anxious about having to have sex in a certain time frame.
Sure, but I have a hard time getting women to take those meds. I mean, I'll tell them they were developed for pulmonary hypertension, but they still wonder why they are taking a med for erectile dysfunction.
The mechanism behind these P5 inhibitors isn't purely vascular. They also enhance dopaminergic transmission in brain regions involved with arousal. So I'll explain that to many women and to men as well.
In the first episode of this series, we warned about androgenizing hormones and polycystic ovarian disease with valproate. Another concern for women is prolactin-raising antipsychotics, and risperidone is the worst offender here. Elevated prolactin causes problems in both sexes: breast engorgement, lactation, bone thinning, and disrupted sex drive and reproductive function. In women, there's an additional risk. For women with a history of estrogen receptor-positive breast cancer, prolactin elevation can stimulate malignant growth, making these medications relatively contraindicated for them when prolactin goes up. Aripiprazole is prolactin-sparing and often the better choice in these situations.
Bone mineral loss is also a problem with serotonergic antidepressants. The risk is similar here in men and women, but women bear a greater impact and they have more fractures because women already have a greater risk of osteoporosis after menopause. Besides the SSRIs and SNRIs, we worry about carbamazepine with the bones because it can weaken bones by lowering vitamin D. So check vitamin D levels on this mood stabilizer, carbamazepine. But there's one medication that is more favorable for bone health. New studies suggest that lithium protects against bone mineral loss. The takeaway: check prolactin levels on antipsychotics, and if you find that it's elevated in a woman with a history of breast cancer, you need to intervene promptly. Avoid serotonergic antidepressants and prolactin-elevating medications in patients who are at high risk for osteoporosis. Use the P5 inhibitors for sexual dysfunction on SSRIs in both sexes, and don't get all rigid about being spontaneous.
Number 11, drug metabolism. Zolpidem is the only psychiatric medication with different dosing guidelines for women, but many other drugs are metabolized more slowly in women. Olanzapine clears about 30% more slowly. Compared to men, women have higher serum concentrations at the same doses of amitriptyline, nortriptyline, doxepin, citalopram, and mirtazapine. Watch for side effects like morning sedation on these. Number 12. Drugs of abuse are more dangerous in women.
The medical consequences of substance use are generally worse for women. Women clear alcohol more slowly than men, and they're less likely to benefit from any supposed health effects of low-dose drinking. Women are more likely to develop alcohol-related medical problems, including cancer, especially breast cancer, as well as liver and heart disease. Women are 20 to 70% more likely to develop lung cancer from smoking than men, even when they smoke the same number of cigarettes.
And we have psychiatry to blame for this. In the 1920s, Sigmund Freud's nephew used his famous uncle's ideas to lay the groundwork for modern advertising. His first conquest, convincing women to smoke. We've come a long way, sort of. Smoking is on the decline, but alcohol use is on the rise in women. I don't know who's responsible for that, but the media seems to be normalizing it. One of my patients blames it on $2 chuck wines at Trader Joe's. Numbers 13 and 14, transgender patients and psychotherapy.
Okay, we're down to the last straws with 13 and 14, and we're going to break the mold here and stop talking about women and psychopharmacology. The next two tips concern psychopharm in the transgender population and psychotherapy across all genders.
Transgender patients carry a higher burden of psychiatric problems. Around 70% have a diagnosed mental illness. but there's no evidence they metabolize or respond to medications differently. If your transgender patient is taking estrogen and lamotrigine, you might expect lower lamotrigine levels. There's no research on that specific scenario, but it would be worth checking a lamotrigine level.
On the other side, if your patient who's transgender is taking testosterone to transition to male, I guess that the testosterone could lower zolpidem levels, so the transition to male might allow them to actually take a higher dose of zolpidem, the 10 milligrams. This is all speculative. Another theoretical possibility with female to male transition is that testosterone is going to increase serotonin transporter binding in the limbic regions of the brain. But whether that actually changes antidepressant response in any clinically meaningful way is totally unknown. When patients transition to male, depression risk does go down a little. And when they transition to female, the depression risk goes up a little. Why that is, we don't know. There's just no research to tell us. The government just cut funding for transgender research, and they're also persecuting people for conducting that research. So while we wish we knew more, we're going to end the speculation and change the topic to psychotherapy.
Here's where we get back to the narcissism of minor differences. Women and men have the same outcomes in psychotherapy, in large study after large study. A possible exception is exposure-based therapy for PTSD and psychotherapy for borderline personality disorder, where women have somewhat better outcomes than men, but the difference is small. Still, there is a plausible mechanism behind it, at least for exposure therapy in PTSD. Estradiol enhances fear extinction.
In other words, estrogen might enhance exposure responses with exposure therapy in female patients. Now, if there's a meaningful difference between the sexes in psychotherapy, it's in engagement. Women are more likely to develop a strong therapeutic alliance, and men are more likely to drop out of psychotherapy prematurely. And I hate to say this, as the differences are very minor, so men, take this with a grain of salt. But there is some evidence that male patients don't match as well with male therapists. It's not a reason for men to throw in the proverbial towel here and give up psychotherapy, but something to watch for and maybe think about competitive transverse reactions that get in the way of therapy. On the other hand, I once heard Marsha Linehan say at an APA conference that she had research showing better outcomes when female borderline patients were matched with male therapists than female therapists. But I don't think she ever published that, so take that with a grain of salt as well, and it's probably a minor difference.
This is an area where the law of averages doesn't broadly apply. So if you're thinking of changing your business plans based on this podcast, don't. Seriously. In the US, female psychotherapists outnumber men by 3-1, and these male therapists are in high demand because plenty of people prefer a male therapist, and there aren't enough to go around. Last week, we learned that sleep apnea is common in patients who present with ADHD, affecting 44% of children and 20 to 30% of adults, or up to 50% if we include all sleep disorder breathing. Today's update tests an FDA-approved ADHD treatment, atomoxetine, in sleep apnea. It's a phase 3 randomized controlled trial by Patrick Strollo and colleagues from the American Journal of Respiratory and Critical Care Medicine. The trial tested a combination pill, atomoxetine 75 milligrams, plus the muscle relaxant oxybutynin 2.5 milligrams, in adults with obstructive sleep apnea who couldn't tolerate CPAP. The study was sponsored by the maker of this combination pill, which is seeking FDA approval.
Here's the rationale behind the combination. Atomoxetine is a norepinephrine reuptake inhibitor, and oxybutynin is an antimuscarinic. Together, they stimulate the hypoglossal motor nucleus, firming up the upper airway muscles so they don't collapse during sleep.
The trial enrolled 646 adults across 69 sites in the US and Canada. 26 weeks, the combination reduced the apnea-hypopnea index more than twice as much as placebo, 44% versus 18%, shifting the sleep apnea severity from moderate to mild and bringing 1 in 5 patients to full remission.
This combination pill targets patients who cannot tolerate CPAP, but it came with side effects of its own. There was dry mouth, insomnia, nausea, and urinary hesitation, causing 21% of patients to discontinue it. Now, most of us are not going to prescribe the muscle relaxant in this study, but what about using atomoxetine alone? 2 earlier phase 2 trials tested that. They found that atomoxetine did indeed reduce hypoxia as monotherapy at around 80 milligrams a day. They were the Mariposa and Schweitzer trials. The combination did work better, but only by a small margin, suggesting that atomoxetine accounts for about 80% of the improvement in sleep apnea in these studies. We covered these earlier trials in the November 2025 issue of the Carlat report, where David Liebers from NYU reviewed combination therapies that are in the pipeline, including another one to consider here, atomoxetine plus trazodone for sleep apnea. Trazodone raises the respiratory arousal threshold at just 50 milligrams at bedtime, reducing nocturnal awakenings in sleep apnea.
The bottom line, screen for sleep apnea in every patient with ADHD. Use the Stop Bang questionnaire for adults and the Pediatric Sleep Questionnaire SRBD subscale for children. If sleep apnea is likely, get a sleep study. And atomoxetine is a reasonable medication to start. This Thursday, join Dr. Aiken and Dr. Joe Goldberg for a SAMHSA-sponsored webinar on deprescribing, July 16th at 3 p.m. Eastern Time. The webinar is CME accredited and it's free. You'll find the registration link on the homepage at chrisaikenmd.com.